a topic which I feel is least talked about and which needs definite limelight for women with diabetes. So, as the name suggests, it's sex, sugar, and struggle, the hidden side of diabetes in women. When we are talking about something about females, we obviously talks things of equality or inequality. As we are moving towards an era where everyone is talking about gender equality, but unfortunately, the studies of sexual dysfunction in diabetes, the scale once again seems to be tilted in favor of the males. The PubMed search of the female sexual dysfunction in diabetes yields less than 900 results, whereas the similar search for the male gender leads to nearly 4,000 publications. I was talking about that more recent data about female sexual dysfunction and diabetes has begun to emerge, but we are lacking the field in Indian data. So if, as an Indian, if you see the recent movie watchers, they can easily correlate with all these movies, clips, which are related to female sexual health. Then obviously we know it's a very popular character, Dr. Arora, the Gupta Rog Visheshagya. So these things should be, I personally feel that female sexual health should be taken into consideration and the taboo attached with it should be casted off, and women should come up to speak openly with their physicians, and the doctors also should create such an environment where the females can easily speak out on their issues. So talking about the prevalence of female sexual dysfunction among premenopausal women, a systemic review and meta-analysis of observational studies published in Sexual Medicines Reviews. After screening 9,292 patients, 440 publications were retrieved for full text reviews. Of these, 135 studies were included in the systemic review. 95 of these studies were assessed further in a meta-analysis. There was a substantial heterogeneity among studies. The prevalence of female sexual dysfunction in premenopausal women was estimated to be 40.9%, and prevalence rate of individual sexual disorders ranged from 20.6 with the lubrication difficulties to 28.2 in hypoactive sexual desire disorder. So prevalence estimate of female sexual disorders vary substantially. Nonetheless, results show that female FSD is a significant public health problem that affects 41% of the premenopausal women around the globe. More research and improved sanitation are needed in this field. Again, if we see, there is a sexual inequalities in medical researches, as I have already mentioned. Historically, medical studies have excluded female participants and they've just generalized the male data to get the female data. The gender gap in the medical research results in a real-life disadvantage for female patients. Again, we've seen that in the sexual dysfunction in women with type 1 diabetes, the long-term findings from DCCT and EDIC study, of all the sexual active women with type 1 diabetes in the EDIC study, 35% met criteria for female sexual dysfunction. Women with FSD reported loss of libido in 57%, problem with orgasm in 51%, lubrication problem in 47%, arousal problem in 38%, and pain in 21%. Unvariate analysis revealed a positive association between the female sexual disorder and age, marital status, menopausal status, microvasculopathy, and depression. However, in a multivariate analysis, only depression and marital status were significant predictors of the female sexual disorders. Again, if we see, frequency of FSD was obviously higher in type 1, in type 2, and any other type of diabetes than in control for any duration of diabetes. Female sexual function index was lower in type 1 and type 2 and in any other diabetic women than in the control. So obviously, female sexual dysfunction is more frequent in diabetic than in the control group, and it is also associated with high BMI. So in another study, we have seen that the prevalence of sexual dysfunction was higher in both the types of diabetes than in the control group, and the female sexual function index mean total score was also significantly lower in type 1 and type 2 than the control group. The data collected was with the socio-demographic and the disease-associated properties forms, the Women's Sexual Function Index, and the Sexual Quality of Life Women Questionnaire. The frequency of sexual dysfunction in women with type 2 diabetes was found to be significantly higher at 85% than in women with type 1. The sexual quality of life of the women were also decreased. In another studies from India, where they have found a surprisingly low prevalence of FSD, and the author have accepted that the socio-cultural barriers may have been responsible for their unusual findings. So in another study which is published in Indian Journal of Endocrinology and Metabolism, and studies that the major sexual function domains affected in diabetic females, a cross-sectional study from North India. Here we have seen that the FSD was seen in 70% diabetic females, desire being the most commonly affected domain. Again, when we compare it with the healthy subjects, the overall mean female sexual function index of 23 in diabetic compared to 29 in the control. So a significant association of arousal and pain domain was also seen with the high HbA1c levels. So coming to in general of the sexual response cycle, the Master and Johnson in 1966, they have divided into four stages: the excitement, plateau, orgasm, and resolution. Whereas Kaplan in 1979 have divided into three: the desire, arouse, and orgasm. So obviously, based on the Bayesian's model, Bayesian suggested that the female sexual response is not a linear progression of phases, but it can be considered as a circular sex response cycle with overlapping phases of variable order. This model also introduced the importance of multiple psychosocial factors such as emotional intimacy, satisfaction with the relationship, self-image, earlier negative sexual experience, which can significantly impair the female sexuality. This is the pathophysiology or the basic mechanism activating or leading to female sexual life, and I won't go into details about it. Now, the organic factors which come into play is hyperglycemia. It leads to dehydration, decreased lubrication, leading to dyspareunia and increased genitourinary infection. The lower urinary tract dysfunction due to older age, obesity, neuropathy, urinary incontinence doubles the risk of decreasing the libido, vaginal dryness, and dyspareunia. The vasculogenic factor due to decreased nitric oxide cause decreased flow to the vagina and decreased lubrication, leading to dyspareunia, inability to maintain orgasm, and the hypoactive sexual disorders. So the clinical presentations of female sexual disorders can be arousal disorder, difficulty in achieving organism or difficulty in achieving orgasms, inactive vaginal lubrication before and during intercourse, dyspareunia, the pain or the vaginismus, the tight vaginal cavity. So the approach for us, for the physicians, should be, we should have a proper history. And first of all, I feel that before taking history, we should make the environment or the chamber or the place where we're taking the history, it should be made favorable. It should be made in unison with the patient, so that the female patient feels comfortable enough to speak out or to speak out their problems in details. So first, we should take into consideration the diabetes-related risk factor in the sexual functions. We should talk about the orgasmic disorder, the sexual arousal disorders, the pain or penetration disorders. The body image can be another factor which can lead to increased incidence of female sexual disorders. Then in assessment, we should go through the questionnaires and the checklist, and then we should go for the management part. So the screening, the International Society for the Study of Women's Sexual Health has developed a process of care that helps to diagnose sexual dysfunction in women. A 4-step model is proposed for those identified with sexual dysfunction. First, we should elicit the story or the history, the naming or framing attention to the problem, then empathetic witnessing of the patient distress is a very important thing. If we be empathetical to the patients and their problems, then they will feel, then we can develop a good rapport with the patients, and they will feel more comfortable in sharing their problem with us. Then there will be the opportunity for treatment the patients. Now, the Female Sexual Function Index 6 is a recently developed survey measuring the sexual functioning of women in 6 different domains. The domains are the desire, arousal, lubrication, orgasm, satisfaction, and pain. This is the gold standard self-reporting instrument for assessment of FSD. The minimum score is 2 and the maximum score is 30. Now coming to the laboratory workups, the selected women should go to laboratory workup for hypothalamic pituitary ovarian axis abnormality, hyperandrogenism, urinary tract infection, autonomic neuropathy, or PIDs. The treatment, there is no specific guidelines actually for the treatment of FSD, but a change in lifestyle, including weight loss and physical activity, plays a pivotal role. 60% obese women seeking bariatric surgery have FSD. The ancillary study of the look ahead evaluated changes in the sexual functions of 229 women in the ILI or the intensive lifestyle intervention group compared with the controls who only received support and education. After 1 year, women with FSD at baseline had an improvement of their female sexual function index compared to their control group. Then again, the psychotherapy treatment of depression, adequate glycemic control is another important step. Hormone replacement therapy can also be tried, but no androgen has been approved by FDA yet. Phosphodiester inhibitors can also be tried. It acts as a smooth muscle relaxation and increasing the vasodilation. Studies also suggest that they might improve the arousal and the vaginal lubrication. Selective estrogen receptor modulator. We have a newer one is the ospemifene, which has been tried for the effective management of vulvovaginal atrophy in postmenopausal women with vaginal dryness. The other non-pharmacological measures can be lubricants, moisturizers, pelvic floor physical therapy, vaginal lasers. So, summarizing up, the deterioration in the sexual functioning is one of the major and serious complications of diabetes. Metabolic disorders affect sexuality through microvascular, nerve damage, and psychological aspects. Several studies have reported a higher incidence of female sexual dysfunction compared with the non-diabetic women. Increased loss of libido, decrease in arousal and lubrication, resulting in painful intercourse and loss of orgasm. All these changes requires a multidisciplinary approach. The take-home points should be, obviously, there are many phases of low libido in women. The take-home points would be sexual dysfunction in diabetic women can significantly impair their quality of life. Diabetologists should address their sexual complaints. Urologists, gynecologists, endocrinologists, psychiatrists should work in a multidisciplinary manner in a united form to get this female patients out of their miseries. And obviously, as I have already told, that we should break the taboo. The taboo is a big hindrance, the big hurdle, I should say. If we break the taboo and can bring forward the female patients to speak about their problem, a majority portion of their problem can be taken care of. Thank you, everyone.